Welcome back to section 17 of the Falcon Physician Reviews Anatomical Review Online. This time we're going to be looking at the muscles of the upper limb, and I think it's really important to have a few general things as ground rules before you spend a lot of time memorizing the muscles and the attachments that have, probably since long been falling out of your brain over the last 2 years. So what I would like you to do is think about the must-knows. You really have to have, for the USMLE, a good understanding of the compartments, the major functions of the muscles within that, as far as groups in the compartments, and the general nerve supply and general vascular supply of those compartments. Don't go into huge and great details, but this is a must-know, and we've been trying to use that in the previous segments with both vascular and nerve supply. The should-knows are not to know every single muscle unless it involves a fracture displacement or root level testing. Those are your high-yield components, so spend your time there and not on every one for specific muscles. And some of the could-knows, if you've already got a good handle on that, you can start to learn some attachments, but don't get too specific on the muscle attachments and don't do it with every muscle. My advice to you would be to focus in on the muscles that have a diagnostic or a clinical differentiation. For instance, in the upper limb, knowing that flexor digitorum superficialis is going to the middle phalanx and the flexor digitorum profundus is going to the distal phalanx for PIP and DIP movements has a significant clinical value in determining what kind of injury or what muscles have been affected. So that's important to know. But other than that, knowing that it crosses the wrist and it's on the radial side is probably enough. If you have a patient that presents with a knife wound to the posterior shoulder, just below the spine of the scapula, approximately 1 inch from the acromion, examination revealed weakened lateral rotation, but normal abduction of the shoulder joint. Which nerve has been damaged? In this case, the suprascapular nerve is what you're looking for. And this can befuddle people in some instances because they have memorized that the suprascapular nerve is involved in abduction initiation and in lateral rotation through the supraspinatus and infraspinatus muscles. And this says that abduction is normal. Well, the important thing here is the relationship of where this injury is, so don't forget to pay attention to the anatomical location of injuries as well. This particular knife wound is posterior and below the spine of the scapula. That will be after the point of innervation of the supraspinatus muscle, and therefore it will not be affected by that trauma. What will be affected is the continuation of that nerve as it comes around the greater scapular notch and takes out the infraspinatus muscle, which would reduce lateral rotation. So therefore, knowing just the muscle's major function and paying more attention to the distribution patterns of the nerve will have a higher yield than knowing the fine details of where those muscles attach. When you think about muscle testing, remember, you have active, passive, and resisted movements. We've talked a little bit about those in lower limb, and this is going to give you information about the particular muscles and what kind of activities have been lost. Here in this was a student of mine that actually had a car accident and damaged their supraspinatus muscle through traction. And they end up with an atrophied supraspinatus and infraspinatus with my fingers easily able to push into the particular muscle bellies. If you look at the diagram showing the distribution of this from the previous question, you can see how the knife wound, which would be inferior to the spine of the scapula, would take that nerve out just as it starts to distribute to the infraspinatus. Here we can look at the rotator cuff muscles, a very important set of muscles, and even with those, if you know that they attach to the lateral or greater tuberosity and then the lesser tuberosity, that should be enough, knowing that they're involved in initiation of abduction and medial rotation for the subscapularis, as well as lateral rotation for the IT muscles. The more important of the areas around here will be the subacromial bursitis. If there's a capsular tear from a rotator cuff injury, oftentimes this bursa will become confluent with the capsule synovial fluid, and it will swell into that bursa, causing irritation and further rubbing against the tendons. Remember, the most commonly injured muscle of the rotator cuff is indeed the supraspinatus muscle. There will be difficulty and pain initiating abduction, which you can test with the Jobe test, or some will call it the empty can test or milk jug test. The other test that you can do will have a drop arm test, which you will ask them to abduct to 90 degrees and then gently tap their wrists, and if their arm drops from that point, they don't have the power to sustain it with the supraspinatus. And also the painful arc, which will typically give them a pain either at the beginning of the initiation and then at the end if it's a supraspinatus, or from 20 through 100 degrees if it's a deltoid weakness or tear. This is just to remind you of some of the spaces and how these nerves will come through both the quadrangular space, the triangular space, and the triangular interval as they distribute. One of the high yield ones for questions would be the quadrangular space with that axillary nerve and the posterior humeral circumflex artery going through it. Now, when you think about muscles of the arm, remember we talked about the fact in the organization that it has two compartments, the anterior compartment and the posterior compartment. In the anterior compartments of the brachii, we really only have 3 muscles and 1 nerve. But there's 2 nerves that just pass on through the compartment. The muscles are all listed here, and you can study those. And then finally, in the posterior compartment, we really only have 1 muscle, which is the triceps, and again, 1 nerve. The musculocutaneous and the radial are the distributors for this one. Now the passers-by are going to be the ulnar and the median nerves. Here you can see those muscles as they distribute. We're going to move quickly through these, but please take your time if you feel you need to buff up on these muscles. Remember that the musculocutaneous nerve actually pierces through the coracobrachialis muscle, which would be a potential site for entrapment. Notice how the brachialis covers the distal half of the humerus, and the coracobrachialis covers the superior half of that, and the deltoid will come in laterally to help sequester it into a compartment itself. And there you can see the triceps with their 3 heads distributing. Notice how the medial head is underneath that tendinous sheath and is only located in the distal half of the area. All of the triceps get their innervation quite high up, as we mentioned earlier. When you think about forearm, we'll summarize that with a flexor surface and extensor surface. There's going to be 2 compartments, a superficial and a deep, in the flexors, and there's going to be 3 compartments in the extensor surface, which is going to be a superficial, a deep, and an outcropping compartment. 8 muscles in the flexors, 5 superficial, 3 deep. 12 muscles in the extensors, 5 superficial, 3 deep, and the 3 outcropping muscles. And then we don't want to forget about this kind of weird muscle, the brachioradialis muscle, which is innervated by a radial nerve, which is an extensor nerve, but actually functions as a semi-pronated flexor. So that's a unique muscle that you need to know something about, not just because of its root testing issues, but also because it's unique in its innervation and its function. Well, I've already talked at length about the different nerves and their distribution to the various compartments in the flexor surface, and you can see the same that we've done with the radial nerve as it distributes through the extensor surface. Remember, if you knock out the radial nerve prior to it crossing the elbow, you'll get a true wrist drop, and that will knock out the brachioradialis muscle and the extensor carpi radialis longus muscle. if you knock it out as a deep radial nerve, or posterior interosseous as it's often called, you will not have a true wrist drop, and you will spare those two muscles. Let's do a question. A 28-year-old framing carpenter who builds houses comes to you complaining of a 3-week history of burning pain near his left elbow. He localized it to his lateral epicondyle. It is warm to the touch, has pain on resisted extension, and also passive stretch. He does not report pain on active extension, but does state that it hurts more by the end of his typical day. What is the most likely diagnosis? In this particular question, we're looking at lateral epicondylitis, sometimes referred to as tennis elbow, but in this case, because he's a carpenter swinging a framing hammer, this can also cause extension problems. It also depends on how he swings. He could even have de Quervain's tenosynovitis from swinging a hammer, which would affect the outcropping tendons associated with the snuff box because of the flexion, ulnar flexion and radial flexion that occurs when you swing your wrist and have to prevent that hammer from swinging past. This is essentially extensor irritation as a result of microtraumas and overuse. And the posterior interosseous nerve entrapment would not give heat, but may actually affect the weakness of these muscles. And the radiocapitellar osteoarthritis would affect problems with pain, but would not give the same kind of heat over the muscles, nor would it have an effect on passive stretch. Ulnar neuritis is going to be on the wrong side, and fibromyalgia is too specific to this one joint to make any sense. Now, if we look at the muscles of the forearm, remember we said there's 5 superficial muscles of the 8 forearm flexors, and we're just going to put these up here. You can, as you need to, look at the distribution of those, but there's one that doesn't cross the wrist, the pronator teres, and there are 4 that do cross the wrist, one on the radial side, one on the ulnar side. The palmaris longus is not always present, but it goes into the palmar aponeurosis, and the flexor digitorum superficialis, remember, splits to go to the middle phalanx of each finger. The 3 deep flexors of the forearm are going to be innervated by the branch off the median nerve known as the anterior interosseous branch, and it will do 1 for each finger again. There's going to be 1 for the 4 medial fingers that goes to the distal phalanx, flexor digitorum profundus. 1 that goes to the thumb, flexor pollicis longus, goes to the distal phalanx as well, and then pronator quadratus, which doesn't cross the wrist. So one way you can remember these is by knowing that you have to occupy 1 tendon for each finger and then have a postage stamp shaped one that doesn't cross the wrist. In the extensor compartment, we have 5 superficial muscles and that weird muscle known as the brachioradialis. The brachioradialis, we said, attaches on the supracondylar ridge, does not cross the wrist, and attaches to the styloid process of the radius, but is a semi-pronated flexor, even though it's innervated by an extensor nerve, being the radial. Here's the other muscle that's innervated by the radial nerve, extensor carpi radialis longus. And now we have a brevis, extensor digitorum, extensor digiti minimi, and extensor carpi ulnaris, all of which attach to the common extensor tendon on the lateral epicondyle. And there's the nerve distribution of those. The outcropping muscles are simply the ones associated with the snuff box, and the deep muscles are those that are just close to the bone. So we have a deep muscle of the supinator wrapping around the radius. We have a deep muscle of the extensor indicis going out to the extensor expansion, and we have the anconeus, which is going to help in slowing the extension of the elbow, or forced extension. The outcropping, we have a longus, brevis, and a longus. And from the distal phalanx is the extensor pollicis longus. From the middle proximal phalanx, it's going to be extensor pollicis brevis. And from the first metacarpal is going to be the abductor pollicis longus. So we have longus, brevis, longus, if you count them down from the distal phalanx on towards the first metacarpal. We have a 44-year-old mechanic who presents with weakness in his dominant hand and complains of dropping wrenches and tools more often at work. He has tingling in the thumb and index fingers at the end of his day and says that sometimes he wakes at night feeling the need to shake his hand awake. The strength in his hand was 4 in the affected side and 5 in the unaffected side. What's the most likely diagnosis? In this particular case, we're looking at a carpal tunnel syndrome. There's a couple red flag signs that you'll see here, but let's go through some of the other options and how they don't make sense. The thoracic outlet syndrome, though it can compress brachial plexus, will oftentimes not have specific distributions, especially off of things that are going to the median nerve, because it's getting contributions from further up, and there would be more than just hand effects. Raynaud's syndrome is going to be an autonomic problem with cold. Dupuytren's contracture is a fibrosis and shortening of the aponeurosis in the palm, which pulls the metacarpophalangeal and the PIP joints of finger 4 and 5 into flexion. It does look similar to a claw hand and some of the other presentation we discussed earlier, with the big key difference is that there's no hyperextension at the MCP. Carpal tunnel we've discussed already, and it makes you more susceptible to carpal tunnel with the use of birth control and infections that can occur. So the motor innervation of the thumb muscles is oftentimes how it's reported, and some cutaneous innervation of the palm will be affected, as well as 3.5 digits of the lateral fingers. Trigger finger occurs when there's a fibrous nub that starts to show up on the sheath, usually through irritation of some sort, and that will happen around. If you look at the palm itself, each of the tendons of the long finger tendons crossing into the thumb as well as the fingers will have synovial sheaths around them. There is a sharing of synovial sheaths that can travel into the wrist from both the 5th digit and the 1st digit, and can cause infections of those fingers to pass that through and into the carpal tunnel. Whereas the fingers of digits 2, 3, and 4 have a more separated synovial sheath, which has less risk for passing that along through a bursitis and an infection there. If there's tenosynovitis as a result of overuse, the thenar and mid-palmar spaces can become infected and distended with fluid, which can come from a penetrating wound in the palm. With de Quervain's stenosing tenosynovitis, this kind of question could be asked, and it will have something in the stem of the question that will result or involve a thumb extension, because it involves the abductor pollicis longus and the extensor pollicis brevis tendons that are near the snuff box. Oftentimes there's repetitive snapping of the wrist, which will cause pain along the extensor tendons. As we look briefly at the supination and pronation movements, remember that there are 3 joints that are moved, the 4 muscles that we've talked about already, which would include the pronator teres and pronator quadratus for pronation, and the biceps brachii is the main supinator along with the supinator muscle. These are going to be innervated by median and musculocutaneous nerves, as well as the deep radial, as is seen here. And as we finish up with the hand, there are 3 compartments, just like we saw in the lower limb in some of the earlier presentations. There's the thenar, hypothenar, and intermediate compartments, and there are 19 intrinsic hand muscles that will be held in these compartments. Only 5 of those muscles are innervated by the median nerve, while the other 14 muscles are innervated by the ulnar nerve. If you simply remember that there's a thenar and hypothenar eminence with the little finger and the thumb, each of them have the same muscles, a flexor, an abductor, and a ponens. That makes 6 of 19. There are 4 lumbricals, 2 of which are innervated by median, 2 of which are innervated by ulnar nerve, and there are 7 interossei, all of which are innervated by the ulnar nerve, the deep ulnar. Then there's an adductor pollicis, which will pull the thumb towards the side of the index finger. Here you can see how those tendons will cross in relationship to the nerves, with the carpal tunnel tendons being 9 tendons and 1 nerve. Then the radial artery will cross posteriorly and into the extensor surface by going under the snuff box tendons. And the ulnar artery and nerve will cross in relationship to the hook of the hamate and the pisiform bone, so that they're protected from compression as they enter the wrist. The tendons of the long flexors will be stacked for the superficialis tendons, and they will be flattened out for the profundus tendons. One of the important things about knowing this stacked relationship at the wrist versus that splayed out relationship after the carpal tunnel is that if there's a superficial wound to the wrist itself, you need to understand which fingers will be affected by that superficial cutting of. Finally, you can see the compartments in this cross-sectional view with the various fingers named. There's the thenar muscles and the hypothenar muscles and the compartments in between. Notice how interossei are much deeper than lumbricals and sit under the long tendons of the hand, and that you can see a nice thick palmar aponeurosis, which is well anchored to the skin of the palm, superficial to all of the structures that are passing through the palm. Here you can see all of the muscles of the thenar and hypothenar eminence, and I think if you know that they exist there, rather than worrying too much about where they attach, that would be time well saved. As far as lumbricals and interossei muscles, remember that there are 4 dorsal. One way I remember that the dorsal ones are 4 in number is that D for door has 4 corners. So a door has 4 corners. The lumbricals are responsible for flexing the metacarpal phalangeal joints while simultaneously extending the IP joints, because they feed into the extensor expansion in the dorsal hood on the dorsal aspect of the digits. Now, injuries to some of these issues or the dorsal expansion can cause finger deformities, such as boutonniere deformity. Boutonniere deformity or swan neck deformity will actually have results from rheumatoid arthritis. If you snap the boutonniere deformity, where either by pulling the median band or slipping the lateral bands around in front of the IP joint, you'll get flexion of the IP joint, which causes passive extension of the DIP. In the swan neck deformity, the reverse happens, which really happens because there's a weakening of the volar or flexor plate at the PIP, and that weakening of it allows it to hyperextend at the PIP joint, which causes passive flexion at the DIP. So they're almost exact opposites of one another, although they can have the same cause, meaning joint deformity. Here's why this happens. When you look at the dorsal expansion and the dorsal hood, you can start to see how those lateral bands would slip in front of the PIP fulcrum point and cause flexion, whereas passive extension would still be pulled at point 2. If you cut point 1, that central slip will then cause the flexion of the PIP and again distal distal joint will be extended. So we'll ask another question. If both the flexor carpi ulnaris and the extensor carpi ulnaris muscle were contracted simultaneously, what movements would ensue at the wrist? This kind of question can be problematic for people because oftentimes they've forgotten specific attachments and they've forgotten specific functions of these muscles. And this is where I think learning the general function of these and knowing where they cross a joint is much faster and better time spent that will allow you to attack these questions with reasonable thought process without unreasonable time being spent on every muscle and their attachments. So what do we really have going on is we have something on the flexor side and something on the extensor side, both near the medial aspect. And if you think of the two muscles pulling and canceling their flexion and extension functions, you can actually see how they would cause adduction, which is ulnar deviation. And we can go back to that simple chart that we used for the lower limb and use it again at the upper limb. If we divide the wrist into two halves with the flexor and extensor surface, we're going to have flexors on the anterior half and extensors on the posterior half. If we divide it again into a medial and lateral half, we have radial deviation and ulnar deviation, also known as ulnar deviation being adduction, radial deviation being AB, abduction. If the tendons cross in this first quadrant, they'll be flexors and adductors. And if they cross in the other quadrant shown here, that's flexor and abductor. Likewise on the posterior surface, just as we saw in the lower limb. Now if we put the muscles and where they cross from that previous question, you can see that the flexor carpi ulnaris and the extensor carpi ulnaris are in opposite quadrants across from one another on the ulnar side. That means that they're going to be flexors and adductors, whereas the extensor will be an extensor and an adductor. If we cancel out our flexion and extension, we can see how the summation of the remaining ulnar deviation would cause adduction. This concludes our sections on the upper limb. In our next segment, we'll be looking at the